Welcome to part 2 of the 4-part video series entitled Medical Mycology from the Perspective of Dermatologists. I'm Maria Caterina Latherin. We proceed to subcutaneous mycosis, which is defined as the chronic localized infection of skin and subcutaneous tissue and adjacent lymphatics. It's usually caused by traumatic implantation or inhalation. Most etiologic agents come from soil or decaying vegetable saprophytes with low virulence. We will be discussing the 4 main subcutaneous mycoses. Sporotrichosis is caused by Sporothrix schenkii. It's usually acquired from plants such as rose thorns and splinters, soil, and vegetation. It is a dimorphic fungi and is seen in both tropical and temperate climates. This infection is commonly seen in miners, agricultural workers, gardeners, veterinarians, forest rangers, and horticulturists. 5 clinical types of sporotrichosis include fixed cutaneous, lymphocutaneous, pulmonary, osteoarticular, and disseminated. Specimen collected can be pus from the lesion, biopsy of the lesion, or sputum and CSF. When cultured at room temperature, it produces cream to black-colored colonies that folded and appear leathery, and they grow within 3 to 5 days. Under the microscope, the molds appear as branching mycelial forms with rosette-like clusters of conidia, which are white to dark brown. The yeast form are spherical to ovoid budding cells, which are cream beige. In tissues, you will see asteroid bodies called Splendor-Heppley phenomenon. Treatment of sporotrichosis can be oral potassium iodide, which is good for lymphocutaneous type. You may also give fluconazole, itraconazole, and terbinafine. Amphotericin B is reserved for the more serious infections. Surgical debridement with your antifungals produces faster and better results. Next is your chromoblastomycosis, which is usually caused by traumatic inoculation of black molds or copper-colored soil saprophytes found in rotting wood. Hyperplasia occurs around the inoculation site, producing crusted warty or tumor-like lesions. You may see these infections in tropical and subtropical climates. You collect specimens from skin crusts, scrapings, aspirated debris, biopsy, or excised material. When cultured, you may see compact, deep brown to black, velvety wrinkled surface. In tissue specimens, you should appreciate spherical brown cells called your sclerotic bodies or copper pennies. These are some of the common organisms associated with chromoblastomycosis. Phyalophora verrucosa, whose conidia are produced from flask or vase-like phyalides with cup-shaped collarets. The mature spherical to oval conidia are extruded from phyalide and usually accumulate around it. Rhinocladiella aquaspersa have acrotheca type of conidation, wherein you find conidia at the ends and sides of the conidiophore. It produces lateral or terminal conidia from a lengthening conidiogenous cell. The conidia are elliptical to clavate shape. Cladophyalophora or Cladosporium have 2 or more conidia found at the tip of the stalk, which may bud and form secondary conidia until chains are formed. This is a homodendron type of conidiation. Terminal conidium gives rise to the next conidium by budding process. Poncacea pedrosoy may exhibit all three types of conidation, namely phyalides, chains of blastoconidia, and sympodial conidation. Most form short branching chains of blastoconidia as well as sympodial conidia. Treatment of chromoblastomycosis includes excision with wide margins for small lesions, chemotherapy using flucytosine, itraconazole, and terbinafine. Relapse is common for this condition. We now go to phaeohyphomycosis. This is a demetiaceous mycelial fungal organism with the following genera. They may present as subcutaneous, paranasal, and cerebral. For culture, the specimens can be skin scrapings, tissue biopsy, sputum, bronchial washings, and aspirates. Surgical excision is the treatment of choice, and antifungals may also be given. Lastly, you have your mycetoma. These are chronic suppurative infection of the subcutaneous tissue and contiguous bone. The feet are the affected area in majority of cases, followed by the legs, hands, head and neck, chest, and shoulder. They present with local swelling, draining sinuses, granules, and tumefaction. The three important criteria for diagnosis are draining sinuses, sulfur granules, and swollen extremities. You have your bacterial actinomycetoma or your fungal eumycetoma. The bacterial actinomycetoma causes 98% of your mycetoma. This is caused by actinomyces or nocardia. They are more invasive, more inflammatory, and more destructive. The fungal eumycetoma is caused by black molds and grows slowly with clearly defined margins and remains encapsulated for a long period of time. The granules of the mycetoma may vary in size, color, and hardness. Specimens for diagnostic tests may be tissue biopsy, excised sinus, or serosanguinous fluid. The granules of bacterial actinomycetes appear as filaments with a diameter of 0.5 to 1 micron, coccoid, and bacillary. The granules of fungal eumycetes are 2 to 5 micra in diameter, with many intercalary swollen cells. Treatment of your fungal eumycetoma include amphotericin B or itraconazole for 1 to 2 years, with not much success. For bacterial actinomycetoma, use dapsone with streptomycin or amikacin with trimethoprim. Surgical treatment for eumycetoma is an option if there's no response to medical treatment. Your key concepts for subcutaneous mycosis are: subcutaneous mycosis may be caused by dozens of environmental molds associated with vegetation and soil. These infections are usually acquired when minor cuts or scratches introduce soil or plant debris containing the pathogenic fungus. The ensuing infections are frequently chronic, but rarely spread to deeper tissues. Sporothrix schenkii is a dimorphic fungus that converts from hyphal to yeast cells within the host. Diagnostic feature of chromoblastomycosis is microscopic observation of sclerotic bodies. Diagnostic feature of phaeohyphomycosis is the presence of brownish septate hyphae. And the hallmark of mycetoma is localized swelling, formation of fistula or sinuses that contain hard granules composed of hyphae and inflammatory tissue. This is the end of the second part of the 4-part video series. See you on the third part.